Hello to everyone who is joining us across the planet. It's absolute pleasure to finally resume our Young IFSO Journal Club. Before we start that, I want to actually especially thank IFSO for the continued support. I want to thank Manuel and Stephanie for always supporting us in our efforts. Without further ado, I think we can start introducing our speakers. This journal club is our sixth Young IFSO journal club, which we'll try to conduct monthly. This will be chaired by myself and Dr. Wang from China. We have speakers. Our keynote speaker is Professor Sergio Santoro from Brazil, who graciously allocated time early this morning from Brazil to join us. I'm sure most of you know Professor Santoro has contributed significant amount to our understanding of metabolic diseases, not just bariatric surgery, but how bariatric and metabolic surgery affects diabetes and resolution of diabetes. He's one of the pioneers in this field. He's a graduate and postgraduate of University of São Paulo, Brazil, and currently is a metabolic surgeon at Albert Einstein Israeli Hospital in São Paulo, Brazil. He is widely regarded as the father of gastric bipartition procedure, which is one of the most promising neuro procedures in metabolic surgery. The other two speakers are Caitlin Russell and John Perrone. They're senior general surgery residents in New Jersey. They will presenting, Dr. Russell presenting Dr. Elchar's paper, and I would like to thank Dr. Elchar for also graciously joining us this morning. His paper on robotic surgery, which was selected as top 10 papers for IFSO Miami in 2021. And Dr. Perrone will be presenting another robotic surgery paper, and I think we're going to have an absolute fantastic discussion. So I will turn to Dr. Santoro for his first presentation.
Good morning, everyone. It's a big pleasure, an honor to be with you at the Young IFSO. Thank you very much, Dr. Tohu. We are going to talk about what are the elements for safe and potent metabolic surgery. Let's start about the stomach. What do we metabolic surgeons want from the stomach? Yes, we do want less ghrelin. It's an orexigenic hormone that causes hyperglycemia, that has anti-insulinic actions, and that elevates glucagon. But we also want rapid emptying because we learned that gut signals are important for the regulation of satiety and the insulinic response. So to obtain the gut hormones in a faster mode, it's interesting. And it brings us to the concept of functional restriction. When you start a meal, the stomach empties very fast and food goes to the gut fastly until we obtain distal gut signals that signal that we have eaten pretty much, and the stomach stops emptying, and it starts to accumulate in the stomach and causing a distension, and this limits the amount of food that you put into the system. So the amount of sugar and fat that you put into the system is blocked by the blockage of gastric emptying. So whenever you are hungry, ghrelin is high and your gut signals are low, and food goes fastly to the gut until you obtain an intestinal satiety. This intestinal satiety is the elevation of these gut hormones that causes you some amount of satiety. And after this point, the stomach stays in the food stays in the stomach, but people keep on eating because of gluttony. Gluttony is not a sin, it's an instinct. And you eat until you feel that your stomach is quite full. and then you obtain this gastric satiety, and they all summed gives you the full sensation of satiety, a satisfaction after leaving your table. But observe that the size of your stomach only matters after you obtain this intestinal satiety that blocks the gastric emptying. Otherwise, the size of it doesn't matter much because it's empty quickly. So we can imagine that there are two types of restriction. A mechanical restriction, that it was the restriction thought by the bariatric surgery, bands, rings, narrow anastomosis. These are static, they're permanent, they're an obstacle to food passage, and they are there at the first bite, limiting your ingestion. While the physiological restriction is circumstantial, it appears at the end of your meal, and it's provoked by a metabolic change and limits your stocking, not your ingestion. So we think we don't want mechanical restriction, we want functional restriction. But we also want a smaller stock capacity after the emptying is blocked. Overeating is not good for the obese or the diabetic. But if you think this sleeve gives it all, it's a tubular stomach with low complacence, with rapid emptying. It retrieves your gastric fundus that retrieves very much, diminishes very much ghrelin. So the sleeve completes this thought about the stomach. However, the sleeve is not sufficient for everyone, for the heavily obese, or it's not sufficiently potent to be a primarily procedure for type 2 diabetes. We can still think about the stomach. What do we gain by putting a minimal gastric pouch? Probably nothing. Nothing. We lose some gastric capacity, some gastric functions. We won't have enough acid to help in the absorption of iron, of calcium, the controlled gastric emptying. We might have dumping. The little stomachs were a thought of mechanical restriction. It's not really helpful when you are thinking of functional restriction. And also we know that bigger stomachs that are tubular can give you even better results. The duodenal switch and the one anastomosis gastric bypass, they have more potent results than the usual bypass. So we don't lose anything by making a stomach a little bit bigger, but it's the opposite. We gain gastric functions. We also don't gain much by keeping the gastric fundus. By keeping it, the fall of ghrelin might not be so consistent. Many works that show that after a gastric bypass, it might be even increase the ghrelin after the bypass. So to finish this thoughts about the stomach, it seems that the sleeve can be the maximal operation that makes sense from the metabolic standpoint. We have never proven that there is additional metabolic gain by retrieving the gastric body or the antrepyloric region. So we need to talk about the intestines. The intestines have to complete this metabolic surgeries. Proximal and distal guts are very different organs. The proximal gut is very cautious about avoiding hypoglycemia. There is very little sugar in primitive dieting. So what you eat doesn't have a big amount of sugar. So you have to release insulin, but very cautiously. In the proximal gut, there is still the maintenance of a stimulus to glucagon secretion, which keeps the gluconeogenesis for a while until you can digest what you have eaten. So gluconeogenesis is maintained by the activity of the proximal gut. This endocrine activity does not block well the gastric emptying, does not cause satiety, and does not end a meal. Obviously, there is food just in the proximal gut. The distal gut is very different. It's very efficient in lowering glycemia and blocking glucagon secretion. And this is important because gluconeogenesis is a central problem in type 2 diabetes, but also a problem in obesity. There is a fractional elevation of gluconeogenesis. Although there is not elevated production of glucose in obesity without diabetes, the fraction that comes from gluconeogenesis is always enhanced. So the distal gut, it is a lot more potent in blocking gastric emptying, but also in promoting insulin sensitivity. This is something very important, insulin sensitivity. And probably FGF19, a gut hormone, is very much involved in this. Distal guts are capable of causing strong satiety, and when properly stimulated, this activity, this endocrine activity of the distal gut ends a meal. Well, our diet have changed a lot. We used to eat this kind of food, very poor in terms of in the amount of calories. The amount of calories is not much, and they are all inside cellulose, which is hard to digest. And recently, we have changed for a big amount of refined diet where the sugars and the fats, they're very free, so very ready for absorption. So we imagine that by changing to modern diet, a lot of the absorption occurs on top, causing a duodenal jejunal hyperactivity, an endocrine hyperactivity besides the absorptive activity. So, by contrast, the ileal is hypoactive because most of the food is absorbed here in these circumstances. So this is exactly what nature does when you enrich diets. If you compare animals that are very similar, but they eat food with less cellulose and more sugar, the stomach gets a little bit smaller and the ileum comes closer. And this is valid for all superior animals. It's valid including fish. So let's observe this surgery of the past, the jejunal bypass. Nobody touched the stomach, nobody operated on the duodenum, and there is a flood of the distal ileum here because food is brought immediately to the distal ileum. And if you see, there is almost immediately resolution of diabetes, in spite of they didn't touch the stomach or the duodenum, just by flooding the distal ileum. And these cases were studied many years later, and it was shown that there was a big elevation of GLP-1 even 20 years later after the surgery. But if you observe all surgeries that send food to the ileum rapidly, like the jejunal ileal bypass, or scopinaro, or duodenal switch, or the bipartition, or the ileum interposition, or the one anastomosis duodenal switch, or the one anastomosis transit bipartition. These are all ileal surgeries. And what is similar among them, they bring diabetes remission about 85% and higher. So they are all very potent. And the ileal surgeries is not just more potent, they're different because they bring insulinic sensitivity. What causes an insulinic postprandial curve that is a lot flatter, so showing that this insulinic sensitivity. Probably many hormones are involved in this, but recently we understood that FGF19, it's a different hormone because it's not produced by endocrine cells. It's produced by the common mucosa of the ileum when it absorbs biliary salts. And this hormone is very much involved in glycemic homeostasis, in regulation of biliary acids production, and the metabolism of lipids. And we know that the low FGF19 is related to coronary artery disease and type 2 diabetes. But most importantly, the activation of the FXR, which is a nuclear receptor in the enterocytes of the ileum, when they absorb these biliary salts, they produce FGF19 and they increase insulin sensitivity, not only in the liver, but also in peripheral tissues. By understanding this, we started to imagine that we do not need any mechanical restriction. Functional restriction would be better. And also, we don't want malabsorption. Malabsorption is a disease. The people that are normally lean, they don't have any malabsorption. Probably, if we obtain this functional restriction and we obtain a good balance between distal and gut hormones and proximal gut hormones, this probably is enough. And this is what we called pure metabolic surgery. It's not based in malabsorption and restriction, which were the pillars of bariatric surgery. So what we did was to transform the duodenal switches, which is a heavily malabsorptive surgery because all the proximal gut is completely excluded, and change it to this. We bring the ileum up because we want this ileal stimulus, but we deactivate the proximal gut just by shifting food from it. We don't want malabsorption. The little amount of food that comes here is pretty much enough to keep you in good nutritional health. But look, it's the same distal stimulus. This is really ileum because we are between 250 and 280 centimeters from the ileocecal valve. Now we use a very, very small limb to protect against the enterogastric reflux because we understood that it's important to have bile here in this segment because the absorption of bile is what promotes FGF19. So we moved in the last years for a longer common channel, which protects us a lot from malabsorption, maintains good intestinal habits of the patients, but gives a lot of potency to the surgeries. It's a simple procedure. It's different than a duodenal switch. It's simple. And it causes this immediate stimulus to the ileum. And the deactivation of the proximal gut is partial. It's not by exclusion. We don't want malabsorption. We have published in 2012 more than 1,000 cases of this technique, showing 86% of remission of diabetes, which is pretty stable over these years. We keep on maintaining these numbers, as I will show you. Typically, most of the food goes straight to the ileum because it has a lower pressure. So food goes immediately to the ileum, and just later some food go to the duodenum when the ileum is already pretty full. All limbs are alimentary. There is food in all segments of the digestive tract. Indeed, this anastomosis drains the sleeve, reducing the high intergastric pressure of the sleeve gastrectomy, but it drains to lower parts and not to upper parts. So somehow it protects from reflux. And the gastroileal anastomosis push the stomachs down, what avoids coiling. It puts the sleeve in a good position. So, it avoids this kind of coiling. It's a substitution of a technical complex anastomosis, which is from the duodenal switch, and that it's a terminal vascularization, and it's the only exit of the stomach. It even might elevate the gastric pressure because in the beginning the motility of this limb is not very well because the pacemaker was interrupted. While we can change it for a technically easier with optimal vascularization, which is an additional exit to the stomach that drains this pressure. So technically, it's a lot easier. And so it's simpler, it's faster, it implies less surgical risk, and it's nutritionally safer with a full endoscopic access. Why can we use a bipartition in grade 1 of patients with diabetes and not a duodenal switch? Because the duodenal switch was designed to obtain malabsorption, and it does, while the malabsorption, the bipartition was designed to avoid malabsorption. We want a pure metabolic surgery. Well, these things were compared. Professor Topar, which is the specialist in duodenal switch, compared bipartitions with duodenal switch just in super obese. He came that it's a lot faster because you don't have to deal with the duodenum, and it has a smaller hospital stay. But the important thing about what he published is that there was no difference in comorbidities remission. The remission was around 90% in bipartitions against an 88. It is the same number. So what is the message? It was not the exclusion that were bringing these results. It was the distal gutic stimulus. Well, we made a randomized control trial just to re-study, because we have already measured these hormones in the past, but we want to re-study the situation. So we compared 10 patients with heavily diabetic, they on insulin, all of them with uncontrolled diabetes and with mild obesity, to medical control. And what you observe is that the glycated hemoglobin in 3 months falls more than 3 points. And in 2 years, 9 out of 10 had a glycated hemoglobin lower than 5.8. The GLP-1 has a big enhancement. We know it. And also, there is a small decrease in GIP, a proximal gut hormone. But maybe the most important thing is that the diabetic, they have a smaller production of FGF19 than the healthy. But when you operate this patient with a bipartition, you will obtain an overcorrection. It multiplies FGF19 by 5. And we think that this is because we cause a ileal hypertrophy. It's the opposite of what refined diet causes. This causes a hypertrophy of the whole mucosa, which are the cells that produce FGF19. But L cells are a proportion, a fixed proportion of the number of mucosa cells. So the number of L cells also are enhanced if there is ileal hypertrophy. And by doing that, in those 10 patients, we obtained 9 out of 10 remissions. This was a small study, but 9 out of 10 is important, because when you see the stampede at 2 years with the same criteria, they had 6 remissions out of 18, 33%. Or if you see the DSS, they had at 2 years with the same criteria, 18 out of 57, 35%. So you have a surgery that the bypass dismounts the anatomy a lot more. Some digestive functions are lost, but the result is worse. And obviously, the sleeve gastrectomy has had even lower results at the stampede. The Turkish have compared sleeves with mini gastrics with bipartitions and ileal transposition, and they came with the fact that the elevation of blood glucose after meals is lower after transit bipartitions. And they came with the result that the lowest, the biggest diminution in glycated hemoglobin was from transit bipartition. And the elevations of GLP-1 were also the biggest in bipartitions because we are stimulating the whole ileum very fastly. And beta cell responsiveness to glucose was greater in transit bipartition. But the conclusion is very important. They conclude that the greater improvement in beta cell secretion and the good results in diabetes, they do not depend on duodenal exclusion, what means a lot from the technical standing point. We don't have to deal with this organ, and we don't have to completely exclude it. Other people have studied the index of remissions of diabetes in bipartition, and here we have 85%, and here we have 94%, and here we have 92%, and here we have 88%, and here we have 83%, 84%, and as you can see, this gastroileal anastomosis is pretty easy. It can be made mechanically or manually, and it can be done even in one anastomosis. The Germans have just published this article. They pick up patients that failed after laparoscopic sleeve gastrectomy. The diabetes was back. They have weight regain. And then they picked up just these worst cases because they already have a surgery, and submitted them to a one anastomosis transit bipartition. And they have shown that they obtained 73% of remissions after a failed sleeve. So all the good cases were already resolved by the sleeve. Just the bad came here, and they achieved the 73% remission in Germany. So I think it was never a question of absorbing or not. Normal people absorb food. It was a question of how and where. A quick word about safety. Dr. Philippe Topar also compared the bipartition against Roux and Y gastric bypass in super obese. And they came with this. TB appeared to be safer when compared with a Roux and Y gastric bypass. So I think that to treat with insulin a type 2 diabetes patient with obesity, maybe it's not ideal. This patient is already hyperinsulinemic, so he has already a lot of insulin. Insulin resistance that is already high will get worse. And insulin is obesogenic. The obesity might get worse also. But worst of all, insulin needs adherence and many doses a day, and makes the life of the patient very miserable. Surgery is one dose, doesn't need much adherence. But what do we really need to make a diabetes surgery included in our routine? We need a surgery that is highly potent. The patient is not going to be operated aiming at a lower potency. We need something that is sufficiently simple to be safe and fast. We need something easy to do, to undo, and to adjust. A diabetic person would have no interest in an excluded segment. Nobody indeed would. No significant malabsorption. We don't want another bad disease. Malabsorption is a disease. We want functional restriction, not mechanical, because of the quality of life. Functional restriction is the normal way to be restricted. We want to correct this proximal distal gut endocrine imbalance. And we want to add insulin sensitivity. Then we want some ileal hypertrophy. Ileal hypertrophy probably is a new goal in metabolic surgery. We want full endoscopic access, especially because these people sometimes are old. They need endoscopic access. A drainage sleeve is very well for your comfort and to reduce the gastroesophageal reflux. By concluding, we want a procedure that is potent like a DS, but with much simpler and much fewer adverse effects. And with these characteristics, we don't have anything other than the bipartition, because it's the only way that we have developed until now to stimulate the ileum very fastly and entirely and very potently without achieving, without obtaining malabsorption. Thank you very much. It was a huge pleasure to be with you.
Thanks so much, Professor Santoro, for this fantastic presentation. Highly educational as usual. If you don't mind, I'll start with the first question, then I'll turn to the panelist. So the surgeries you mentioned, the classical gastric bypass, sleeve, duodenal switch, single anastomose duodenal switch, single anastomose gastric bypass, or gastric bipartition. If you had to find ideal patient for each surgery type, what kind of patients would that be?
Do you hear me?
Yes, please.
Well, nowadays in our daily practice, what we are using is the sleeve in the very easy cases of both obesity and very mild diabetes. And in any kind of harder cases, more obesity or more metabolic disease, we use the bipartition. And the gastric bypass is becoming more and more competitive to a Nissen procedure. We are reserving it for the bad case of reflux when there is obesity together. So in my mind, the Roux-en-Y gastric bypass now becomes a competitor for Nissens in obese. And for all the other cases in where we want metabolic procedures, I think that we have better options.
Thank you. Any questions from the panel, please?
Yes, I think Professor Santoro, you should turn on your camera.
I'm trying to. Somehow it doesn't work. There's the beer webcams.
By the way, may I ask your opinion?
Yes. Oh, it's stopped. It's stopped. I don't see you. It stopped.
While War is coming back, let me ask a follow-up.
For the metabolic surgery on young onset diabetes, treatment is not quite in medical not the first option for them. So I would like to hear your opinion on this.
Excuse me, I didn't hear your question. There was a failure in the sound.
Okay, and my question is, may I ask your opinion on metabolic surgery for the young onset diabetes?
You mean people that are young and obtain a type 2 diabetes with a good pancreatic reserve? Oh yes, I think that it's okay because we have to protect the beta cells. We have to protect these patients from the bad consequences of high glycemia over time. Usually there are a lot of other associated diseases with diabetes. So I think that when we detected this, we can interrupt it, especially with the surgery that doesn't cause any severe problems like the bipartition, because the nutritional condition is very, very good.
Mm-hmm. And which procedure will you recommend for the young onset diabetes patient? For example, sleeve or gastric bypass or bipartition?
if there is a diabetes that is being installed early in life, it means that will be it has a potential to be a bad diabetes. So I would not see a reason why not to do a bipartition, especially because it's very both easy to do and to undo. So and we know that high levels of GLP-1, they protected the beta cell mass. They protected the pancreatic function over time. So maybe you can give for this person longer protection.
Okay, thank you very much.
So, Professor Santoro, I have a question. Moritz Felsenreich from Austria. So we want to be transition in Austria, but I have a question on that. The concerns I heard about this method is that if you have two ways the food can go through, you will never know how much of food will go to the pylorus and how much will go through the anastomosis. So you said 70% and 30%, but the concerns I heard about this procedure are that it's maybe in 1 or 2 years the anastomosis can close up again, or there will be nothing through the pylorus. Do you have a comment on that?
Oh, yes, this is a very common question. First of all, any ileal stimulation would be better than none. So, but this is not the case because the ileal is preferential. If you see the GI series of these patients, you will see that food goes straight into the ileum because the ileum has a lower pressure than the duodenum. That's why food goes from up to down and not down to up. There is a pressure gradient and there is no pylorus. So what you have is an immediate stimulus to the ileum. In the beginning of a meal, almost practically all of it go to the ileum. Just later, when the transit, the intestinal transit is slowed, that you see food go into the duodenum and the proximal gut. And this amount of food that is not much is completely enough to keep the structure of mucosa, to give you the endoscopic access, and to keep you in good nutrition. Probably we are eating a lot of calories and a lot of everything. This little amount that goes to the duodenum, it's completely enough to avoid you from bad nutritional problems.
Okay, thank you.
I would like to remind everyone that for further questions, please feel free to use the chat. We can definitely read your questions there and voice it that way. Just one more follow-up question, Dr. Santoro, just real quick, if you don't mind, in just a couple sentences. Where do you see the future research on gastric bipartition to bring it to the mainstream of metabolic surgeries?
Well, we are still living in a world where restriction and malabsorption are in the minds of the surgeons. And now it's completely clear, there is no doubt about that mechanical restriction and malabsorption, they don't play a role on this. So I think that there is no sense in keep on using procedures that were primarily designed to obtain some kind of mechanical restriction and exclusions and malabsorption if the problem is just hormonal. I think that what solves this is the wide use that is spreading all over the world now. We have many groups doing it in many countries in all continents, and we are coming with these numbers, remissions. Everyone that has measured the index of diabetes remissions in this procedure have obtained more than 80%. So by repeating this and by observing that it's a lot better to have all tissues are working, we have all epitheliums of a digestive tract working. We have all epitheliums of the stomach. We have duodenal epithelium working. We have jejunal epithelium work. We have ileal. Everything is working. This protects you from nutritional problems. This gives you no blind loops are kind of sick because the mucosa interacts and nourishes from the nutrient that is passing. So any excluded limb, besides being excluded for endoscopy, is also a limb that's not completely healthy. So I think we are moving from the concepts from bariatric surgery to the concepts of pure metabolic surgery.
Dr. Santoro, just one more question, if you don't mind, please, from the audience. Do the limb lengths differ with the BMI of the patients you operate on?
Well, since we understood that bile was a necessity for the production of FGF19, we have enhanced very much the common channel. And it happened that what was observed in SADI was also observed in transit partition. We enhanced the common channel. Since it is in ileal territory, it doesn't change very much the weight loss or the results, but the nutritional conditions of the patient get better and better with longer common channels. So we are in a very safe territory now, so we don't have to worry much about changing limbs because bad malabsorption won't occur in any way.
Understood. Thanks so much for your time, Dr. Santoro. I truly appreciate your fantastic presentation. It was educational as usual. Thanks so much for coming here. And we will move to the next presentation. The next presentation, Dr. Russell will be presenting Dr. L. Char's paper. I would like to say thank you, a separate thank you, Dr. L. Char, one more time to be able to join us. We will be presenting his paper, Robotic Surgery Results in Better Outcomes Following Gastric Bypass. It's a large mebiscope analysis from 2015 to 2018. Before we start the presentation, I would like to do the first question poll. All right, so in most of the institutions from the audience who joined, robotic surgery is not available at the institution. Thanks so much for everyone who voted. Dr. Russell, we'll let you present, please.
Hello, everyone. I'm Caitlin Russell. I'm a surgery resident from New Jersey in the US. Super excited to be here presenting our first paper in the 2021 Young IFSO Journal Club meeting. Let's go ahead and get started. So this paper is out of St. Luke's in Pennsylvania in the US, L. Char et al., reporting robotic surgery results in better outcomes following Roux-en-Y gastric bypass, MBSA QIP analysis for the years 2015 to 2018. When we talk about obesity and bariatric surgery in the US, it's important to note the context. Over 2/3 of Americans are considered to be overweight or obese based on BMI, and the necessity of effective therapies is greater now than ever. As far as bariatric surgery is concerned, it is, with repeated data and repeated research, been shown to be the only safe and long-term effective treatment for obesity. Medication, diet therapies, all these tools are available to us as providers treating bariatric patients. However, the only thing that to date has been able to show real long-term effectiveness in a safe manner is bariatric surgery. When we talk about bariatric surgery in the last several decades, it's important to also discuss the advent of conventional laparoscopic and robotic assisted surgery in these patients and in these platforms. As these surgeries have become more and more commonplace, it's understandable the expansion into the Da Vinci robotic platforms for these patients as well. However, the therapy itself remains controversial, largely because of the lack of robust outcome data, both short-term and long-term, in this particular patient subset and for these particular procedures. It's also, of course, always important to note costs when we're talking about providing a therapy for an individual, both to the institution, to society, as well as to the individual itself, which is something particularly important in the US healthcare system as well. When we talk about metabolic and bariatric surgery in the US and the research thereof, it's virtually impossible not to mention this large database, the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. This is a large combined database between the American College of Surgeons and the American Society of Metabolic and Bariatric Surgery, which joined forces in 2012 in combination to combine their databases as well as to regulate and administer appropriate both training of bariatric surgeons and licensure of bariatric surgeons, with the goal, as stated, to recognize those facilities that implement defined standards of care, document their outcomes, and participate in regular review to evaluate their bariatric surgical programs. As of 2019, which is the most recent year of data, 868 centers have been accredited underneath this umbrella database and submitted over 200,000 cases to this database. So it's really an incredible wealth of information that's available to both us in the US and everyone internationally to look at and use as a tool for the research and study of bariatric surgery and bariatric patients. When looking back to this study in particular, we find that their objective was to evaluate the outcomes and safety of the most commonly performed anastomotic procedure in the United States, which is the Roux-en-Y gastric bypass, and compare laparoscopic approaches using this large bariatric clinical database. As far as the methods and the design of the study are concerned, the main features of this study that set it apart both from prior studies of bariatric patients as well as studies using this database in particular are twofold. First, that the two groups are propensity matched for several criteria, which I'll go through specifically later, looking both at conventional laparoscopic and then robotic assisted laparoscopic surgery. And then also that this patient group had a strict exclusion criteria for any patient who had had a prior bariatric surgery or any type of foregut surgery. What this allows the researchers to do is to make conclusions about this very specific type of bariatric patient, one who's having their first surgery as a laparoscopic or robotic assisted gastric bypass without any of the additional surgeries as prior history, as well as looking at a very direct comparison between the two through the propensity matching. Then when we look at the outcomes that they investigated, the primary outcomes that they state are adverse events, infection, bleeding, reoperation, and intervention, whether it be endoscopic or interventional radiology. Secondary outcomes were readmission, conversion to open at the initial surgery, the length of the procedure itself, length of hospital stay, and mortality. All of these criteria and all of these specifics are looked at as far as outcomes are concerned at the 30-day mark, because that is the breadth at which the MBSA QIP database records. As far as statistical methods are concerned, SAS macro green match was used as the matching criteria for the propensity matching, looking at age, gender, ASA classification, and an extensive list of clinical variables that we'll see in just a second. And they ended up with a matched cohort of about 22,000 patients, about 11,000 per each group. For the subgroup analysis, the variety of different types of outcomes required a different set of statistical tests, using chi-squared for the categorical outcomes, t-tests for the conversion rates to open, Mann-Whitney tests for the continuous outcomes like length of stay, and then Cochrane-Mantel-Haenszel tests for the single variable approach that they use to look at a specific subset of patients, being a BMI over 50 patients for specific outcomes to these individuals. When we look at the matching of our two groups, we look at the conventional laparoscopic and the robotic assisted surgery patients. And you can see here the variety of different predisposing conditions that the patients were matched upon: diabetes, hypertension, sleep apnea, cardiovascular disease, et cetera. And the standardized differences between all of these groups being very, very low, meaning that we have the ability to make robust conclusions as these two are good standardized groups to compare to one another. When we look at the results of our primary and secondary outcomes, first with the primary outcomes, comparing the conventional laparoscopic and robotic patients, initially what we see is the severe adverse outcomes and bleeding rates requiring transfusion are significantly lower in patients undergoing robotic surgery. When we talk about things that were shown to be less frequent in the conventional laparoscopic patients, we see the reoperation rate within 30 days was significantly lower in the conventional laparoscopic patients. When we look at primary outcomes for the patients that had a BMI over 50, both severe adverse events as well as organ space infections were shown to be significantly higher in these patients. While this is something of concern, it did not show that there was a link between either the robotic technique or the conventional laparoscopic technique between the two in these types of complications. When we look at the secondary outcomes for these patients, comparing conventional laparoscopic to robotic, we see that in both operation length and 30-day readmissions, they were less with the conventional laparoscopic patient. It's not surprising given the standard for operation length with the robotic surgeries that these are shown to be longer. That is consistent with prior published data as well. However, when we look at hospital length of stay, patients were seen to be in the hospital for a shorter period of time when they underwent robotic surgery as opposed to conventional laparoscopic surgery. For secondary outcomes for, again, these subset of patients with a BMI over 50, we see that the 30-day mortality in these patients is increased in both the conventional laparoscopic and the robotic group. This is also consistent with previously published data showing that patients in this super obese category with this increased risk is consistent with increased mortality. When we look at these data and these publications, it's important to note that the number of patients that are undergoing robotically assisted surgery in these databases and overall throughout the US in this time frame between 2015 and 2018 was about 15% of cases. However, as time has gone on and the adoption of robotic technology in these cases has increased, the number of bariatric cases being done with robotic technology has increased year over year. So while it was a small subset of patients at the time of this data being collected, it's significantly more patients now. So these data and this research is more and more important as this becomes more and more adopted widely. When we talk about this paper as relative to other retrospective studies, particularly other ones that use the MBSA QIP database, the advantages that I mentioned in the study design show through as well. And when we talk about the robustness of their result as compared to other papers as well. The propensity matching was very significant and very extensive, and that does allow us to draw some more significant conclusions as a result, as well as the isolation of the Roux-en-Y gastric bypass with no prior history of surgical intervention on their stomach or their foregut. This again really focuses in on a very specific patient type, one who's undergoing Roux-en-Y gastric bypass as their primary surgery, their first bariatric surgery, and doesn't draw conclusions about the other potential therapies, and as a result has the ability to make a stronger statement about these patients in particular. Also, of course, we need to discuss the limitations of the paper. Many of these limitations, if not all, are ones that unfortunately apply to any research or any publication that's using the MBSA QIP database for their data. And the limitations there are ones in particular related to time frame, where, as I mentioned previously, they look at 30-day outcomes and really nothing beyond that for these calendar years that we're discussing, as well as the type of data that's collected. In particular, there's not a large breadth or a detail that's allowed to be inputted or was allowed to be inputted when it comes to exact operative technique and the technologies that were used. So for example, there's no indication as to which robot system type was used for these patients, as well as no indication of the type of techniques that were done in each individual surgery. For example, there's no indication as to whether or not a stapled anastomosis or a hand-sewn anastomosis was being made for any of these individual patients, which obviously is well documented to have significant effects on adverse outcomes for these patients. In addition, the database does not allow for any sort of indication as to whether or not trainees were involved in the operations or aftercare of these patients, as well as the surgeon experience individually. So these are all things that are well known to affect the outcomes for an individual patient and are not yet recorded or included in this data. Of course, when we talk about next steps in the determination of robotic efficacy or equivalence in these patients and in laparoscopic surgery in general, the gold standard will always be randomized clinical trials. And that is something that is still as of yet lacking for these patient groups in particular, but should be forthcoming. In conclusion, the paper states the overarching takeaway that they would like for you to have from this paper is that the use of robotic surgery in Roux-en-Y gastric bypass results in better short-term outcomes as compared to laparoscopic surgery. Thank you.
Thanks so much, Dr. Russell, for this great presentation, a fantastic paper. I would like, before going with the questions, before opening the questions to the panel, the second follow-up poll, please. Thanks so much for everyone who voted. Once again, at least 1/3 of the respondents just don't have availability, and other 1/3, if they had availability, they may use the technology for their practice. Just before we ask questions regarding this specific paper, I just want to ask an open question to all the panelists who is joining us from around the planet. In the United States, there's significant increase in adoption of robotic technology for general surgery and specifically for bariatric surgery. I just want to ask everyone, Erin, Maureen, Alexander, just everyone around the planet, how's the robotic technology usage in your countries?
Can I comment? Thank you for the question and for the nice paper. The problem, like we have a robot in our clinic and we have an X-eye one, and I just started using it. But the problem is the cost, because still it's very expensive, and many of the patients cannot pay from their pocket, and the governments, they don't want to code it. We cannot code the robotic procedures. And the other problem about the robot is that it's very easy for me. If I get all tingling on my fingers, I can use the robot and do every surgery. But for the patient, when it comes to learning curve, in some clinics, it takes 7-8 hours when they start the robotic procedures. And that might also affect the patient's safety. And when I look at the paper, I saw something. The readmission rate was really low in a laparoscopic group. And the thing is, I think we need more and more new robots, maybe a different kind of robots in the future, because it's also a problem that only one company is now like dominating all the robotic procedures in the world. Maybe if we have more robots, then the cost will go down and its usage will increase. Thank you very much.
Absolutely, that's a very important thing to point out in this paper in particular, but it's also good to note that the readmission rates in both groups were actually very low, and that's pretty indicative of this surgery being well tolerated overall. But that's definitely, cost is always a big part of the conversation when it comes to the adoption of these technologies, absolutely. And the development in particular of the new robotic technologies, and in these instances, in these surgeries in particular, the development of the new stapling technology is a huge difference in the way that we're able to consistently and safely perform these procedures. And as that becomes more and more readily available, I imagine that that should help assist, of course, with cost over time, but it's certainly something that is a very large barrier to entry.
Kostas, Evan, thanks so much for your input. Truly appreciate it. It's very interesting for me to understand the view from around the different countries. But at least in United States, the cost is such a difficult thing to estimate, especially when we compare robotic surgery to laparoscopic surgery. You know, my cost for laparoscopic sleeve or bypass is not the same in every single hospital. Each hospital have different contracts with different companies. It is such a variable thing. And there are a lot of papers actually showing that robotic bariatric surgery or robotic general surgery is not that expensive, and in some instances actually cheaper than conventional laparoscopic surgery. Once again, it depends on the hospital, depends on the contract. But the cost is such a complex topic to discuss. But yes, it's important topic to discuss nevertheless.
So in Austria, the problem is that we are really try to reduce the time of the procedure and the time between the procedures. And we have now implemented a fast track concept where we are able to save from one to another procedure about 15 minutes or something. And currently we need, for doing a one-anastomosis bypass or also root gastric bypass, between 40 to 55 minutes. And I think we would really increase our time if we do these procedures with an robotic. This is the hugest problem in Austria about that.
It's definitely sorry, go ahead.
Yeah, so we have a similar situation in Malaysia because Renu from Malaysia. So I work in a university hospital, and in a university hospital, we don't have access to the theater for elective cases 24/7. It's reserved for emergency cases. So we need to call the last case by 3:30 p.m. or it won't be done. And if we're embarking on robotic technology, then I agree with Moritz, it's going to take more time than we have in our hands, and that's going to limit the number of cases that we can do in a day. And it being a government institution, that's going to push our waiting list from 3 to 6 months to maybe a year, 10 months or a year. And that's one of the reasons, besides cost being the biggest reason, because the cost difference between a robotic bariatric surgery and a conventional laparoscopic bariatric surgery in Malaysia is about 10,000 ringgit. May not seem so much in USD, but it's a lot here because healthcare is heavily subsidized by the government. We have government hospitals charging very, very minimal cost, which is absorbed by the taxpayers' money because we don't have a national healthcare system. So that's going to put a huge dent in the government missionaries if we're going to be embarking on that. Plus, if it was a cash paying patient also, it would mean, yeah, 10,000 is a lot here. So yeah.
Yes, those are definitely two very well-established barriers to entry for, unfortunately, the robotic technology, both in bariatric patients and patients across the board. And when you speak to Intuitive about the time frame that it takes for someone to basically get back to their
their pre-robotic adoption timeframe for being able to complete these surgeries. They talk about 30, 50, 100 cases, and that is a serious commitment as far as time, energy, and it is really something that requires both institutional support and cost payer support, depending on what exactly the system is, in order to have that planned ahead, so that it's not something that comes as a shock to anybody, either the cost or the time frame that it does take to train both, not only the surgeon to learn the technology, but the staff as well is particularly important.
Morris, if you don't mind, oh, I'm sorry, Karen, please go ahead.
No, just in Czech, the situation is exactly the same. It's a matter of money, and mostly it's indicated for a surgery of prostata in urology and for some operations on ilex. No bariatrics now. In the past, there was one institution that performed bypasses and mini-gastric bypasses, but they totally stopped there.
Thanks so much. Morris, if you don't mind me asking a follow-up question on your comment, how many cases did it take you and your group to establish 45-minute gastric bypasses? Morris, can you unmute yourself, please?
So for if someone start, we have a very standardized procedure for all these procedures, for one osmosis and one gastric bypass. And I think from 50 to 100 procedures, then you would be below 1 hour, of course.
Right.
For the standard BMI between 40 and 55. I think this is possible, yeah, especially in women.
Correct. Okay, thanks so much, everyone. I think we'll move to the third presentation, and Dr. Perron will present a paper on learning curve regarding robotic bariatric surgery. Go ahead, Dr. Perron.
Okay. Hello, my name is John Perron, and I'm from the St. Joseph's University Medical Center located in Partition, New Jersey, America. Today, I'm going to be discussing an article called Robotic Assisted Surgery Enhances the Learning Curve While Maintaining Quality Outcomes in Sleeve Gastrectomy, a preliminary multi-center study. This paper was published in Surgical Endoscopy in December of 2020 and comes to us from the New York Presbyterian Hospital, Cornell School of Medicine. Despite traditional patient concerns that bariatric surgery is dangerous, the addition of modern technology, such as the robotic platform, may be helping to improve this perception. Annually, there are over 6 million robotic surgeries completed in hospitals around the world. In regards to surgical training, there have been increased efforts to include robotic training as part of the general surgery training curriculums and minimally invasive surgery fellowship programs. Early incorporation of robotic training could potentially lead to the achievement of safety and efficiency benchmarks, even in the first few years of a new surgeon's practice. Literature suggests that the robotic platform may reduce challenges that exist associated in this patient population, included to the limited working space and limitations of the morbidly obese abdominal wall that come with this patient population. In addition, the robotic platform aids in surgeon and assistant fatigue. The aim of this paper was to compare technical efficiency during the first year of practice after completing an advanced MIS fellowship that included significant robotic surgery training. The primary outcome of technical efficiency was evaluated using the metric of operative time. Secondary outcomes of perioperative morbidity were also assessed to demonstrate maintenance of quality standards. So this study included patients from 2015 to 2019, included 313 patients, and broke the patients down into the mentor cohort, Mentee 1 cohort, and Mentee 2 cohort. The mentor cohort having 257 patients, 45 patients in cohort Mentee 1, and 11 patients in cohort of Mentee 2. All locations where the surgeries were performed were MBSQIP certified comprehensive centers of care, and adult patients undergoing primary robotic assisted sleeve gastrectomy with or without hiatal hernia repair without mesh and no other concomitant procedures were analyzed in the study. Patients underwent bariatric surgery based on NIH criteria after appropriate clearances and nutritional counseling. Patients routinely underwent endoscopic evaluation and pH testing as deemed appropriate by the surgeon prior to surgery. The primary outcome, as stated, was operative time, which was measured from skin incision to final port closure. Secondary outcomes of morbidity included enteric leak, strictures, venothrombotic events, reoperations, conversion to conventional laparoscopy or open surgery, length of stay, readmission rate, and death. As far as the surgical technique, the procedure selection was determined by the attending surgeon and was based on patient preference and presence of comorbidities. But there were similarities between all the procedures performed. The Da Vinci Xi robot platform was used for all operations. Access to the abdomen was gained with a Varus needle. 3 8mm ports and 1 12mm port were placed in linear arrangement across the upper abdomen, approximately 20 to 24 centimeters inferior to the xiphoid process. Liver retracted with a 5mm high epigastric port and the use of a Thompson retractor. If there was a hiatal hernia that was encountered, it was dissected free from the esophagus, and the hiatus was closed with a 2-0 or 3-0 V-lock suture. Any relevant hernia sacs were excised. The sleeve gastrectomy was performed using a 40 French bougie and the endowrist robotic stapler. The final staple line was oversewn with a 3-0 V-lock suture. As far as the perioperative pathway, all patients were given preoperative antibiotics with aerobic and anaerobic coverage and 5,000 units of subcutaneous heparin. Per ERAS protocol, a tap lock was performed laparoscopically prior to the conclusion of surgery. Intraoperatively and postoperatively, opioids were minimized. Patients did receive Tylenol, Colocoxib, gabapentin, and Arepitant. Patients were encouraged to take sips of clear liquid diet within 8 hours of the procedure. Upper GI series were not routinely performed in the mentor cohort beginning in 2017. Likely, no upper GI series were routinely performed in either of the mentee cohorts. For analysis, this was performed using GraphPad Prism software version 8.3.0. Continuous variable of operative time was compared using the Kruskal-Wallis test or the Mann-Whitney U test. Linear regression analysis was used to determine the relationships between operative time and case number for all surgeons, with a cutoff value of less than 0.05 being used for statistical significance. This is our table 1, looking at the age and male, female, and BMI, ASA of all of the patients that were involved. You can see that none of the values really reached statistically significant differences, with age ranging in the early 40s, most of the patients being predominantly female, with a BMI of roughly 43 to 46 on average. And there you can see the ASA grades as well too. This is table 2, takes a look at the breakdown from year to year of the mentor group in 2015, 16, 17, 18, and 19, as well as the operative times for Mentee 1 and Mentee 2. And you can see further breakdown within each year of the standard deviation, minimum 25th percentile, median 70th percentile, and the maximum operative times. This is table 3. This takes a look at the operative times by year. The mean operative time statistically decreased every year for the mentor as compared to the previous years, as we can see here. After the first year, the operative time decreased by 26.3 minutes. After the second year, an additional 15.9 minutes. After the third year, an additional 15.7 minutes. And after the fourth year, an additional 7.2 minutes. In comparison from the first year to the last year, the mentor did decrease his operative time by a total of 65.1 minutes. Now, in regards to of how Mentee 1 and Mentee 2 fared versus the mentor operative years, this table analyzes that. And what we see here is that the Mentee operative times at the end of the first year of practice were significantly faster than the mentor's times in the first 3 and 2 years respectively for Mentee 1 and Mentee 2. However, these times did show that they were significantly longer than the mentor's times in the last 2 years and 1 year respectively of performing this procedure. For Mentee 2, the difference of the times compared to the mentor in the 3rd and 4th year did not approach statistical significance. In regards to the improved numbers that we see for Mentee 1, the operative times were 46.8, 20.5, and 4.6 minutes faster than the mentor's 1st, 2nd, and 3rd years. And Mentee 2's operative times were 52.2 and 25.9 minutes faster than the mentor's 1st and 2nd years. Here we see a box and whisker plot of the operative year with the box and whisker plots demonstrating the 10th, 25th, 50th, 75th, and 9th percentiles for the respective mentor and mentee's operative years. X-axis representing the operative year, the Y-axis representing the operative time in minutes. In regards to perioperative outcomes, a total of 6 venothrombotic events occurred, 1.9% of the time in the mentor group, 2.2% of the time in the mentee group, and no events occurred in Mentee 2 cohort. This did not reach statistical significance. There was 1 intraoperative complication occurring in the mentor group. That was a transected temperature probe during the stapling. There were no reoperations in the entire cohort. None of the procedures were converted to conventional laparoscopy or open surgery. 90-day readmission rates were 6.2 in the mentor cohort, 6.6 in the Mentee 1 cohort, and 9.1% in the Mentee 2 cohort, not reaching statistical significance. We do see a statistically significant difference in the mean length of stay in the mentor group, which was 1.8 days versus Mentee 1 group of 1.3 days and 1.5 days of Mentee group 2. In the entire patient cohort, there were no leaks, strictures, or deaths. A couple interesting points as far as the discussion goes. There is no established number of cases in robotic surgery to predict an adequate learning curve. However, there were cases in literature discussed in the past that proposed a learning curve. Zacharoulis proposing a learning curve of 68 cases. Villalonga reported a minimal requirement of 20 cases to achieve proficiency, and Romero did find a decrease in operative times following as little as 25 cases of robotic sleeve gastrectomy. In this study, the mentor achieved a continuous and steady decrease in operative times with a mean of 74.7 minutes during the last year of the studied period. This study demonstrates the ability to transfer procedure-specific skills to a fellowship trainee, as evident by the operative times and short-term outcomes during the first year of practice. Mentee 1 completed 172 robotic cases during the fellowship year, including 58 bariatric procedures, while Mentee 2 completed 179 robotic cases, including 63 bariatric procedures. This allowed the fellows to replicate outcomes with similar operative times to the mentor's 3rd year of practice. Pitfalls and technical aspects of any given procedure are encountered and overcome during the initial learning curve. In our case, the mentor was able to transfer a more polished and improved technique to the mentee, who in turn was able to replicate efficiency in the operating room during the first year of practice. One of the big things that they cite is the docking time, which the mentor had achieved a time of less than 10 minutes from initial skin incision to robot docked, which they attributed was able to be passed on to the mentee and lower the times that you see. There were some limitations of the study. This was a retrospective study with a relatively small sample size in the mentee groups. Institutional bias could explain the small difference in the length of stay that we saw that reached statistical significance. The length of stay decreased for the mentor group after initiation of the ERAS protocol, but this did not reach statistical significance. At the mentor and mentee 2 institutions, surgery residents were also involved in different aspects of the procedure, which could confound some of the results. In conclusion, the study was able to conclude that despite preliminary, this is one of the first series to show that robotic platform can safely be taught and thus translate into outcomes consistent with more experienced surgeons while mitigating the learning curve as early as the first year in practice. It did say also that additional studies are required to assess applicability outside of our training fellowship, as well as long-term follow-up of the mentee surgeons. These are my citations. Thank you very much.
Okay, thank you very much, John. And do we have a poll? So do you currently use or plan to use robotic surgical technology in your practice? So let's see the results. So 38% say no, but most of them are trying to plan if it's available. So are there any questions or comments from the panelists? Any comments or from the audience? If no, John, may I ask, in your opinion, for the trainees, do you think we should master the laparoscopic skill before we train the robotic surgery?
No, absolutely. I think you know, essential. You know, as we just decide our previous discussion, there's not always times when the robot is available, due to emergencies, what have you, just availability. So there's no reason to limit a patient going to the OR based on availability. I mean, I think in the future, as we see robotic surgery expand and more hospitals, more robots, there'll be even. But I think laparoscopic skills are essential, and the stepping stones to robotic surgery.
Okay. So Maurice, Catherine, or Theo, or Kaylin?
Just to expand on what John said as well, I know that when very early on in our training, even as residents, before we sort of decide that bariatrics or minimally invasive surgery is something that we want to pursue, the sort of general adage about robotic surgery in general is that a lot of the techniques and the way of proceeding with the operations is more similar to that of open technique than some of the adaptations that were made to accommodate both laparoscopic instruments and laparoscopic techniques. So in some ways and in some operations, there's been thinking that it reinforces older techniques and sort of brings back some of the thinking that was used in the original open approaches, as opposed to some adaptations that were made for a laparoscopic approach. So the two in combination do seem to have an added benefit when it comes to training.
And I see in some brands, they have invented the robotic arms, not the full robotic systems. Do you think that it will it replace the robotic system in the near future? Because maybe it's cheaper or more easily to access in for some hospitals.
It seems as though the two in combination would be great to have both options available. I know sort of the overarching vision for a company like Intuitive is to almost essentially have a subsection of the OR where the entire equipment and the entire system is embedded within the physical space of the OR. So it's not a pod or a unit that's brought to an individual room. It's something that just exists as part of the infrastructure, as do a lot of systems for laparoscopic technology now. However, having both things available and being able to especially handle cost in which is, as we discussed earlier, such a big barrier to entry, having the individual technology available would be incredible. Things like the 3D camera and the indocyanine green technology integrated into that is in some laparoscopic platforms, but not all. Those things as individual components would be fantastic.
Any other comments?
What do you think about the robots that are having this modular system? Just every arm is their own system, same like we have it now for the new Medtronic. I think it's called Hugo. You can use only one arm or two arms, or as much as you like.
Yeah.
Well, I know. Go ahead, John. Sorry.
So, I mean, at our facility, we use the DaVinci Xi system, and you have the ability to use, all four arms of the robot. And the nice thing about it is, with the old system, the camera could only go in the select locations. Now you have the ability to move the camera and any arm to any to any port. So it's a much more degree of workability and accessibility of the robot.
And I was just going to say that I know John and I, as trainees, are always happy when we have the robot, in the sense that it is a much better replacement for standing static retraction than us as trainees like to be. So that's always useful.
Okay. By the way, may I ask, what's the percentage of robotic surgery in your center, in your hospital?
It depends on the surgeon, and we have a bariatric surgeon in our facility that is strictly laparoscopic. And Dr. Talashinsky, I would say, is increasing his robotic usage. Is robotic in maybe 50% plus of his cases. But we have actually seen over the course of my time there, more and more surgeons getting robotic trained. 2, 3 alone within this past year that were strictly laparoscopic before.
And I had asked our representative about that, in particular for bariatrics in the US, and he said that the numbers that I had stated for the 2015 to 2018 timeframe for our bariatric database had said that about 15% of bariatric procedures were being performed robotically, and now it's about, from this last year, it's about 27%. So a pretty significant increase in the last couple of years.
Okay. So any more comments? Tao, you are so silent today. So if no further question, and I thank you very much for everyone for joining us today, especially our 3 speakers sharing their experience and their data. And I would like to remind that the Young IFSO Journal Club meeting is hosted every month. So if you want to present your data, you can contact us, or you have any senior surgeons want to recommend them and to share their experience to our young colleagues, you can also contact us. We can make some arrangement So I would like to close this session if no other comments. So thank you very much, and I would like to wish you a Merry Christmas for that early and a Happy New Year. Yeah. So thank you.
Thank you.
Thank you.
all.
Thank you.
Merry Christmas. Bye.
Bye bye.
Bye.
Keep in touch.